All right. Good afternoon, everyone. Welcome to our next session in our geriatric boot camp. We are on week 8 now, and this week we're going to be talking about UTIs. We encourage you all to utilize chat. Please put your questions throughout the sessions. We'd really like to hear from you all about any questions that you might have. We have a very great speaker for you here today. Before we get into that, we do have a couple of housekeeping items we would like to get through first. So if you're not familiar with who we are the iPro QIN-QIO. iPro specifically holds the federally funded Medicare QIO contract for the region shown here and works with health-centric advisors who help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. Clarent helps support Maryland, Delaware, and the District of Columbia, and iPro helps support New York, New Jersey, and Ohio, all together under the iPro QIN-QIO banner. So if anyone asks if you know who iPro is, or if you're working with health-centric advisors or Clarent, or if you're working with the QIO, you say yes. And at this point, I'd like to pass it over to Mary Ellen to give us an update on COVID-19. Mary Ellen?
Thanks, Josh. So hospitalizations are stayed pretty level this week. We're still seeing over 19,000 COVID-19 hospital admissions per week. That's a slight decrease of 3.1. However, deaths have increased as they have from prior weeks at 8% as of the 23rd of September. The variants haven't changed. That's the good news with the new COVID vaccine out. The XBB lineage continues to be the dominant strain. EG.5 is part of that, and as you can see, it continues to be the variant that is causing the most disease. Next slide. So just a reminder that CDC updated their recommendations for the new 2023-2024 updated COVID-19 vaccine. It is a monovalent vaccine. Everyone 5 and older should get 1 dose of the updated Pfizer or Moderna COVID-19 vaccine. And there are recommendations, a little more detail with folks that are moderately or severely immunocompromised. I will put that link in the chat. And as a reminder for folks that are reporting to NHSN for COVID vaccines, the definition of up-to-date did change as of the 25th of September in alignment with what the CDC just recommended, that you are reporting for up-to-date someone who received a 2023-2024 updated COVID-19 vaccine, or they've received a bivalent COVID-19 vaccine within the last 2 months. And just note that the bivalent vaccines are no longer authorized as of the 12th of September. So you should see that trickling off, but you may have cases where you've had patients or residents that have recently had the bivalent. So that does count if it's within the last 2 months. And that's it. Back to you, Josh.
Thanks so much, Mary Ellen. And at this point, I'd like to pass it over to Dr. Yassine Abul, who is the Assistant Professor of Medicine and a clinical educator with the Brown University Geriatric and Palliative Care Medicine Center. He's also a researcher research center, and we're very excited to have him here today to talk about our urinary tract infections and asymptomatic bacteria in nursing home residents. Dr. Yassine, over to you.
Oh, thank you. Thank you for inviting me. Hello, everyone. So I hope everybody is hearing me and there is no connection problem. All right. So today I am going to discuss about approaches to urinary tract infection and asymptomatic bacteriuria in nursing home residents. Please go to the next slide. Next slide, please. I have no conflicts of interest to disclose related to this presentation. Next slide, please. This is about me. I am not going to go over everything here. I am a geriatrician, and also I was trained in the infectious disease and pulmonary, and I am doing some research about COVID-19 vaccination and high-dose vaccinations in older adults. And I am also interested in the pulmonary vascular diseases from COVID perspective, and also infection control in nursing homes. Next slide, please. So this is my presentation plan. So first, I will try to define the asymptomatic bacteriuria, and I'm going to use this abbreviation ASB, and based on the IDSA criteria and the definition. And then I will try to make a statement about what is asymptomatic. And we will go over this, what are the common symptoms of urinary tract infection also. And I will discuss about the epidemiology of ASP and why is the recognition of ASP is important and why ASP should not be treated and what are the indications of treatment in ASP. And finally, I will go over the diagnosis and treatment of UTI. And I will also try to emphasize on some challenges in long-term residence because they are different. Next slide, please. So this is the definition from Infectious Disease Society of America, IDSA definition. When we look at this definition, we do see asymptomatic bacteria is the presence of one or more species of bacteria growing in urine culture at specified quantitative counts. So first, we should have one or more species. So it could be one or two or three. So and they can count and specify the reports about the colony forming units. So the next one is, as I bolded here, specified quantitative counts. So when we say specified quantitative counts, it's colony forming units. And it can be in milliliter or liter, 10⁵ and the power of 5 at 10⁸ colony forming units. And another thing is irrespective of the presence of pyuria, regardless of the pyuria actually. So we should not look for the pyuria in this setting, and we should look for absence of signs and the symptoms attributable to the urinary tract infection. So number one is the species, that could be one or more, and the second one is the quantity is important for the definition, and that doesn't matter whether we have pyuria or not, and we should not see any signs and symptoms for the urinary tract infection, which is hard for the long-term patients as well to differentiate. We will come to that point. Next slide, please. So when we say asymptomatic, so we should concentrate on the symptoms. So asymptomatic bacteria refers to patients who have no symptoms, specifically referable to the urinary tract infection. Next slide, please. What are the symptoms? So first one and the most common one is the burning sensation, as all we know, so which is dysuria. And when we say urinary frequency and urgency, so it is tricky actually for the long-term patients and also geriatric patients because they have increased frequency and urgency sometimes without having any urinary tract infection. So we will come to that definition and that symptom later on. And suprapubic pain is another symptom, maybe sign, I can say, because we may palpate and see whether the patient has suprapubic pain or not. And that could be a good sign and good symptom to get some idea about whether this is asymptomatic or symptomatic. Fever is another tricky one because they may not spike fever like other younger adults. So, but in definition, classically, fever with the cystitis symptoms, those are the symptomatic definition. And whenever we see flank pain, that is a sign of complicated UTI, like a pyelonephritis, as all we know. And also another physical exam findings, maybe the sign, I can say, costovertebral angle tenderness in patients with acute complicated UTI. So those are the common symptoms, and some of them are hard to differentiate in older adults. Next slide, please. So when we look at the epidemiology of the asymptomatic bacteriuria, so we should ask this question: how common is it and how prevalent is it? So when we say prevalence, so prevalence is a measure of disease that allows us to determine a person's likelihood of having a disease. So we are talking about the likeliness of having a disease. And those are the very impressive numbers, as you can see here. And older adults residing in the long-term care facilities more commonly have ASP compared with the general older population. So at these numbers can reach to 50% in women and to 40% in men living in long-term care facilities. And these numbers are very impressive, and that means we do see those patients a lot. Next slide, please. So when we compare this prevalence rate with the outside of the nursing home, so woman and the man who lives outside the nursing home, we do see these numbers. So even these numbers are actually on the higher side. So 10 to 16% in older women, and almost up to the 20% in men who lives outside the nursing home. But when we compare it with the previous slide, so it's 50% in nursing homes. So that's an impressive difference as well. Next slide, please. So when we say asymptomatic bacteriuria, the next question is what are the risk factors? So as you can see, first of all, being an older adult is a risk factor. Why? Because they have dysfunction of the urinary system, and they have decreased immunity, which we call with this fancy name immunosenescence. And it means the immune dysfunction by the time being, with the aging actually. And particularly older men have also prostate enlargement, which can cause also decreased prostatic secretions and inability to acidify the urine, and more problems about emptying the bladder. So those are the common risk factors to have asymptomatic bacteriuria or bacteriuria in older men. When we look at the older adult women, so we do see bladder prolapse because of the pathophysiological mechanisms and the frequent pregnancies and the labor. So another one is the estrogen deficiency in postmenopausal period. So estrogen is good to prevent colonization, but if it is deficient, it can enhance the colonization of the vaginal entrance, and it can cause bacteriuria, and somehow it can put all these postmenopausal older adults into the urinary tract infection risk. So another one is incomplete bladder emptying. By the time being, with aging, this is the problem as well, as we know. And the physical impairment is another problem. And mental decline and dementia, another problem to completely empty the bladder. So incomplete bladder emptying is a real risk factor from the point of both aging, physical impairments, mental decline, and the dementia. Next slide, please. So this is a good question, actually. Why asymptomatic bacteriuria, ASB, should not be treated? And when we ask this question, literature says morbidity and mortality are unchanged in long-term care patients. I think I need, oops. There you go. Morbidity and mortality are unchanged in long-term care facilities. So when we treat those patients, we are not making any difference from the point of morbidity and mortality. So it's not changing. If we do not treat, so the morbidity and mortality is not changing either. And when we treat patients with asymptomatic bacteriuria, we are just temporarily eliminating the bacteria from there, and it's coming back because of all these risk factors. That's why we should not treat patients with asymptomatic bacteriuria. And when we treat and eliminate bacteria, as I said, it's coming very quickly and it's causing high recurrence rate of bacteria after antimicrobial prescriptions. That's why we should not treat asymptomatic bacteria. Next slide, please. There are other actually points about not treating the asymptomatic bacteria. There is no difference in mortality rates of the people with ASP living in nursing homes compared with the mortality rates of those with asymptomatic bacteria living outside of nursing homes. So there might be an assumption that nursing home patients are more frail and more sick with more complex comorbidities. That's why we should treat asymptomatic bacteria, or whenever we see bacteria in the urine, we should treat them because they are more frail and sick compared with the outside nursing home patients. There is no difference actually from the point of mortality rates. So they followed those two groups and they couldn't see any difference. So that's why we should not treat asymptomatic bacteria. And additionally, we can assume that if we do not treat asymptomatic bacteria, nursing home patients or long-term patients may decline from the point of functional status, their renal functions get worse, or they can become like more symptomatic, like a urinary tract infection. It can proceed to the urinary tract infection. Actually, there is no such information as well. And those functional decline, renal failure, increased symptomatic infections are not resulting from the asymptomatic bacteria if we don't treat it. Next slide, please. So differentiating the two entities are particularly important because treatment of ASP will do more harm than good, actually. So this is a good statement based on the previous information and data, because we are going to cause more bacterial resistance, and bacterial resistance is going to cause some kind of multi-drug resistant microorganisms, and it will escalate the overuse of the antibiotics. It's like a closed circle. Next slide, please. So this is another important slide. Why is the recognition is so important? So recognition is so important because of this information. And you can check this data from CDC as well, which is very, very actually impressive. When we look at the long-term patients during the 1-year period of residency in a nursing home, almost up to the 70% of residents will receive at least one course of antimicrobial therapy based on the literature and the CDC statements. So most often these orders actually most often means 75% are for the supposed infection, for the presumed urinary tract infection. And again, up to the 75%, 3 out of 4 are unnecessary. These are the solid information actually from previous data and from CDC. So why this is important? Because we are losing our antibiotics to fight against real urinary tract infection, and we are causing more problems by inducing genes to cause multi-drug resistant cases. So 15 years ago, so when I was doing a residency in my previous life, so the ESBL was the problem. So ESBL is extended spectrum beta-lactamase bacteria. We were using ceftriaxone, we were using ampicillin and ampicillin sulbactam at that time, unnecessarily, and we were inducing the genes to produce ESBL. So, but right now, ESBL more than ESBL, we are causing problem with using meropenem, ertapenem for the ESBL microorganisms, which are not real urinary tract infection. That's why we have right now CRE, carbapenem-resistant Enterobacter. And the Enterobacters are causing urinary tract infections. So, and we are losing our guns, real guns, and we are just trying to find another solution. So this is why the recognition is important. Next slide, please. So as I said, bacterial resistance is important, but other entities and the other things which are important is adverse drug reactions. Most of our residents have long medication lists. So if we put another medication which is unnecessary, and if it is antibiotics, we may cause, or we can likely cause some adverse drug reactions. And we can induce actually drug-drug interactions unnecessarily. And obviously we can induce resistant microorganisms without providing benefit. Next slide, please. But we have to treat some of the patients for the asymptomatic bacteria. So I just wanted to put 3 things here. So it may not be relevant for the long-term patient, most likely, but some of them might be relevant. So pregnancy is number 1. Patients undergoing urological intervention. This is our point, actually. So if somebody in the nursing home is going to go to, let's say, TURP operation, transurethral resection of the prostate, or any stenting, if that somebody has a bacteriuria, we have to treat. We must treat it, actually, because it may cause problem, because we are going to just push all the stuff into the upper urological anatomic size, and we will cause most likely pyelonephritis or sepsis. That's why we have to treat it. Another evolving and the rising issue is renal transplant patients, and some of the experts stays within short period of time after renal transplant. Some of them says 2 months, some of them says 3 months. If there is a bacteriuria, even they are asymptomatic, we should treat it. So renal transplant recipients are the ones we should think more to treat it, depending on the timing of the renal transplant, and we should communicate with the transplant physician about treatment, and we should go from there. But definitely the patients undergoing urological intervention is the ones we should treat. Next slide, please. So those are the recommendations to reduce antibiotic use. So why I put this one here, I just want to go over one by one. So these are recommendations from CDC. And first, we should vaccinate. So you can ask me, is there any vaccine for the urinary tract infection? There are ongoing studies right now, particularly for the most common microorganism, which is E. coli, for phase 2, and I'm not sure about the 3, but phase 2 trials for the vaccination. And in future, we may vaccinate those patients who have frequent urinary tract infection or who have asymptomatic bacteria to prevent the real urinary tract infection. We don't know yet, but we will learn more within the next couple of years, maybe sooner than later. We'll see. And definitely every nursing home should have a defined policy and the protocol to get the unnecessary devices out. So this is also very important. So written documents are very, very important, and the following the written documents are also very important to get the unnecessary devices out. Another one, diagnose and treat infection effectively. If there's a real urinary tract infection, yes, we should treat, but if there is no symptoms, we should hold off, and we should have some criteria for diagnosis of the infection, which I'm going to show a very good criteria in a couple of slides. And we should use antimicrobials wisely, which I already emphasized on importance of this one. So we should know when to say no, and also we should know when to say no to actually test for the UA and the urine sample. If there is no symptoms, if patient is doing very well, so with color change of the urine, there is no indication, or if there is any smell change or something like that, there is no indication to test it, because we are going to find something there and we may give unnecessary antibiotics. And stopping the antimicrobial treatment is another important point. We should definitely have the stopping date whenever we admit the patients into the nursing homes. So unnecessary antibiotic use. So nursing homes are very hectic environment. And so if we have an outbreak, they are more hectic. And so we can actually miss the stopping date. So whenever we admit the patient, we should put stopping date, and we should have a solid plan from the point of antibiotic storage. Other things are prevent transmission. So isolation is the number one thing, and hand hygiene. So those are the very important steps we should follow. And if we have a multi-drug resistant organism in any identified resident, so we should pay more attention to that room for the isolation, and while going inside and outside, follow the regular protocols and precautions. Next slide, please. So those are the similarities and differences, which I already mentioned previously, I think a little bit. Let's go over together. And when we see asymptomatic bacteria, and the urinary tract infection, they have both similarities. So we have the positive urine culture in both classification, and we have pyuria. So, but that's not necessary actually for the asymptomatic bacteria. Sometimes it is not necessary for UTI if there is a stone or something like that. So we may not see pyuria as well. So differences, that is actually depending on the symptoms. So if we see non-specific symptoms, asymptomatic bacteriuria is the one. If we see actually very specific symptoms like a dysuria, fever, chills, those are the suprapubic pain sometimes is helpful to differentiate UTI and the asymptomatic bacteria. And we call these ones the localized symptoms. If there's a localized symptoms, we can say, yes, that could be urinary tract infection. If there is no localization in the urinary tract anatomy, so we can say asymptomatic bacteria. But sometimes it is hard to differentiate. We will go to the next slide and we'll see. So we have some challenges for the real urinary tract infection in older adults. First of all, this is the most common infectious illness in adults over 65. We do know that part. What are our challenges? So when we look at the challenges, older adults have higher prevalence of chronic urinary symptoms, right? So they have frequency and incontinence. So this is the challenging part. And also they have cognitive impairment, whether it is mild or moderate, or they have dementia or not. So this is the actually most important part also. And as we know, so they have bacteriuria, so which is staying there because of all these anatomical problems and also functional problems from the point of urinary tract itself. So there is an asymptomatic bacteria there. Next slide, please. So that's why good understanding of the patient's usual symptoms is important, and to detect any meaningful and persistent changes. So those are the keywords. I should have bold them actually: usual symptoms and meaningful and persistent changes. So if the patient has usual symptoms like incontinence, and which is his or her baseline, so that could be asymptomatic bacteria. We should not actually check for the UA or urine culture. But let's say it is getting more frequent, really more frequent, and we have other persistent changes. On top of that, we have some kind of fever response or baseline fever change or any suprapubic pain. So we may go into the direction of the urinary tract infection. So I will give you a good prescription for that one in next slides. Next slide, please. But looking at only non-specific symptoms is not an indication for checking UA or urine culture. So those include functional decline, behavioral changes, mental status changes. So although older adults may present with atypical signs and symptoms, most older adults with an infection will also present with some localizing signs and symptoms. So this is a very important sentence actually. Yes, they may have some functional decline, behavioral change, mental status change. At that point, with that mental status change, if they have a urinary tract infection, they will have some localized symptoms. Next slide, please. So those are the evidence, growing evidence indicates that these non-specific features are not reliable predictors of bacteria or UTI. There is no evidence that treating bacteria in patients with delirium, falls, or confusion improves outcomes. This is very important as well. And patients with dementia have normal fluctuations in behavior. So every fluctuations in behavior does not mean that UTI. So that was also shown that, and frequency of asymptomatic bacteria in this population is high, which we already know that one from other literature. And urine testing will often, if we test it, we will often, we will see something there is a positive culture. Next slide, please. So this is a minimum criteria for initiation of antibiotics. So LOEB, LOEB criteria, maybe I'm pronouncing incorrectly, but LOEB criteria. So this is an old criteria, almost more than 20 years. So I think I was a last year medical student at the time. And it was published, and I think it is the best. So if somebody has a indwelling catheter, at least one of the following we should have: fever. But as you know, fever is not I can say is not similar with the younger adults. So if we see 100 Fahrenheit, that's fever for the older adults based on this criteria. Also, you can check the previous fever pattern. If you see any increase in 1.5 Celsius or 2.4 Fahrenheit from baseline, that's also fever. And that's a great point, actually. So we are doing research about this one also. I think that's a great point, which was caught 20 years ago. And new costovertebral angle tenderness, which is very important in residents with indwelling catheter. That's a sign of the urinary tract infection. Rigor. So if they are shivering, if they have chills, that's a good sign. And new onset delirium. So we are seeing some residents, they are so calm. Yes, they have some kind of mild cognitive impairment or dementia, but all of a sudden they are developing some delirium. So that's an alarming sign for UTI. That's correct. Without indwelling catheter, acute dysuria, again, we had the fever criteria, same here, and at least one of the following. So those are the list, which are localized symptoms, actually. The keyword is localized. So we should look for these criteria to start antibiotics in long-term care residents. Next slide, please. So those are the cases. I am not sure I have time, but quickly I can go over. So this is the 82 years old lady with long-standing history of incontinence, and she's complaining about suprapubic pain, and temperature is 99.6 Fahrenheit. What would be the next step to look for? So next slide, please. So we should look for first the other vitals and the baseline temperature, which I already gave you the keywords and the key points. And suprapubic tenderness is concerning. So we can just press on that area and we can see whether there is any pain or not. It is not so sensitive, but the baseline temperature is always more helpful. Next slide, please. Yeah. So those are similar cases, 72 years old, female with history of dementia and with chronic Foley catheter who is acting differently and more agitated, confused, and she has also degrees attention. And same patient with chronic Foley catheter with some fluctuations in attention deficit and confusion. So which one we should start the antibiotics? So the keyword is actually acting differently, more agitation, degrees attention. So that looks like a new delirium. But regular fluctuations and like a usual word is usual fluctuations may not be standing for the urinary tract infection. And it's still hard to differentiate, and that's a difficult case actually. Next slide, please. So what is the patient baseline? So that's very important, actually. So what is the patient baseline to decide about whether we are going to test or not? If we already tested, whether we are going to start antibiotics or not. 70 years old gentleman with known asymptomatic bacteriuria with all these urine culture who is planned to have transurethral resection of prostate. What is important here is the procedure. So we are gonna induce that procedure and we may cause sepsis. So we have to treat it. Next slide, please. And this is a very good, actually, concert diagram to emphasize on urinary tract infection treatment or not in long-term patient. This is not wonderful, excellent, but this is good. So first question is, if we have an abnormal urine analysis or urine culture, can the patient communicate symptoms? If yes, we have to communicate. We have to ask regular localized symptoms and signs, and we should go from there. If there is no symptoms or signs, we should say, oh, this is asymptomatic bacteria, we don't need to treat. If there is localized symptoms, more than usual symptoms or signs, yes, that would be urinary tract infection, we can treat it. If patient is not communicating, if we do not trust that communication from the point of dementia and cognitive impairment, so we should look for the non-specific clinical changes. If those are non-specific and not localized, not more than usual from baseline, whether this is UTI or asymptomatic bacteria. At that point, I think we should ask this question. So, is this patient severely ill? Do we have other abnormalities like tachypnea, tachycardia, fever? Those are the things. And if the patient is severely ill, we may need to treat actually. So this is the hard part, and this is more clinical sense, and we don't have another test for that one. That's our call actually. If patient is not severely ill, if we do not have other, which I mentioned, other localized symptoms and signs, so we can closely follow and see maybe this evolving process. So I think that's a good way to decide about whether we are going to treat or not. I think that was the last slide. Those are my references, and I would be more than happy to answer questions if there's any in the chat. You can ask me.
Yeah, thank you, Dr. Abul. I appreciate it. And I'm not seeing anything in chat at the moment, so I'll give people a moment if they have any questions or want to come off mute to feel free to ask you some questions. And while people are typing that in or getting ready to ask a question, I do want to share with everyone that we do have an upcoming education summit that's coming out on November 30th from 9 a.m. to 3 p.m. We have a lot of great topics talking about, hospital and nursing home collaboration, managing chronic pain, PTSD, health equity, NHSN and MDS updates, QAPI, substance use disorder. So a lot of great topics for folks. I'm going to put a link to that into chat for anyone who might be interested to register for the event. Dr. Abul, I'm not seeing any questions in chat, so I think we'll be all set to close out the session for today. We do have a comment from Sheila thanking you, saying that it was very helpful.
Oh, thank you. Thank you. I love feedbacks and I love questions, but I think I covered everything most likely. There.
Yes, perfect. So here's our contact information, everyone. If you feel free to reach out to us for any questions you might have, or if you need any additional support with your quality improvement initiatives. And before you leave, if you could just put a quick comment into chat, providing any feedback to Dr. Abul, it is very helpful as it helps inform future presentations. So be sure to put a quick note into chat before you head out for some feedback.
And the document slides, yeah, I think. Oh, thank you. Thank you. I think, do you guys send all these documents to the participants?
Yes, so that I'll be able to follow up with the slides to everybody after the session.
Awesome. I think there is a question here. When residents go to the hospital after a fall, they come back with ABT for UTI. When results received not through UTI, by the time we get cultures, patient has already been gone up. Yes, that's true. Unfortunately, yeah. That's the common problem actually. So at that point, I think stopping the antibiotics is a good call with the available data and information. Thank you.
All right. Thank you so much, everyone. That'll be it for today. Have a great day.
Bye-bye.